there are some new slides and some new concepts, but if remember my talk from a couple of years ago, you can go have coffee or have a pee break or whatever. So I'm hoping that one day this talk will also be no longer necessary. As we get earlier diagnosis and immediate starting of cysteine depleting therapy, hopefully in the newborn period, and with the new gene therapies that are coming on, I'm hoping that I can retire this talk or focus on other diseases. But for now, this is the state of the art. And this is relevant when you have a kidney transplant, but also if you're preparing for a kidney transplant and for your next kidney transplant. Because with the best of our knowledge, if you get a kidney from a deceased donor, the average kidney lasts 11.5 years. If you get a kidney transplant from a living donor, that average kidney in the US lasts 19 years. So which means if you get a kidney transplant when you're 20, that's the first. Now we're hoping that for your next kidney transplant, or in 5 or 10 years, you may get a kidney from a pig, which is genetically engineered to match your immune system, or maybe a mechanical kidney, or a kidney that was printed with a 3D printer in a lab, or grown from your own cells. So this isn't the way it's going to be forever, but this is for today. So these little lines, and I'm sorry I don't have a pointer which shows on all the screens, but the differences in colors show that over the years we've been getting better at caring for patients with kidney transplants. And so although the average kidney transplant survival is 11.7 years, in another 5 years it's going to be better because we keep making progress. But there's a clear difference between the deceased donor and the living donor. The living donors are always better. Now, I want you to walk away from this discussion realizing that the creatinine is not the thing to think about when you're thinking about your kidney function. You need to convert the creatinine or whatever your doctor gives you to the GFR. So, and you can do it if you're an adult with an app, which almost every hospital now has. And so this is my lab, okay, on my iPhone, and I had gotten some labs, test results, metabolic panel, and there is my creatinine, and below that is an estimated GFR. Now that's an estimate based on assuming that I'm like your average build, your average height, but that's an easy way to get it. For kids, it's more complicated, and we'll get into that in a few minutes. Now the GFR, a normal GFR is above 90, and then as your GFR falls, we call it stage 1, stage 2, stage 3, stage 4. And that has different implications. At different stages, you start needing medications to help you maintain your blood counts. You need medications to keep your bone healthy and things like that. So, and then when you're approaching, stage 4, which is the severe reduced GFR, that's when you should start feeling some symptoms, maybe. Most people don't feel symptoms until they're less than 20 GFR. I've seen patients who come to a gynecologist and say, I'm 16, I haven't had a period. And they've got a GFR of 12, and they're a straight A student, they sleep a lot, but they're maintaining. I've seen other kids who come to an orthopedic surgeon because they've got lumps in their bones. And after soccer practice, I remember one girl, she was a cheerleader, after cheer practice, her bones would hurt. She had kidney failure, her GFR was less than 10, but she was maintaining straight A's. So you have a tremendous amount of kidney reserve. So you might feel perfectly well and have a GFR in the 20 range, which is the time when you need to start making a plan for dialysis or a transplant. So most people don't have symptoms with a GFR above 20. Now, creatinine, which is what most of us always get tested on, is made by muscle. So this little girl might have a creatinine of 0.5, and that would be pretty normal for an 8-year-old. Guess the creatinine. Now, I don't know for sure, this isn't a HIPAA violation, but just based on other people's body masses, I would say Arnie in his weightlifting prime had a creatinine of 2.3. Now, if I had a creatinine of 2.3, I'd be looking for someone to be a living donor for me, right? Because my kidneys would be very bad shape because he has a huge amount of muscle, and so it's normal for the creatinine to be up. He goes into the movies, creatinine comes down a little bit. He becomes the governor of California. That's my creatinine. So you get the picture. So you have to interpret the creatinine based on the body, okay? So this is a patient that I looked after, and at about 16, this person used to be very adherent with their medicines, but at about 13, Mom started finding pills in the pockets. He went to summer camp. Mom called in a panic. She was cleaning the room and found hundreds of pills under the bed. And so these are the creatinine values. And for people who are not from the United States, from Canada or Europe, I've got micromoles as well. And so when you just graph the creatinine values, it looks like over time, the serum creatinine was 1s and then 2s, and then it kind of went up at the very end. It looks like, oh, something's going wrong. We need to figure this out. There's been a sudden change. But and see, there you go. It just looks like it's going up, and people say, all of a sudden it's getting really bad. But if you take the creatinine and you plot it based on the biology, based on the GFR, it's a straight line, and you could have predicted this. So, unfortunately, the serum creatinine and the GFR don't have a straight line relationship. So it takes some thinking to figure out what is your GFR from your creatinine. So it's not this, it's this. So as your GFR, which is on the X, goes from normal over 100 down to 75, down to 50, the plasma creatinine on the Y hardly changes at all. But then when you go to 50 to 25, it starts really changing, and 25 to 10, it's changing much more quickly. But it plots to a straight line on the GFR graph. So this is just another example of what I'm trying to tell you. So this is on the left, this is serum creatinines, and this is a person's GFR graph superimposed. That red line is going from 1 to 2. And then from 2 to 3 is a much shorter line, and from 3 to 4, and 4 to 5. So this is why, it might take forever to go from a creatinine of 1 to 2, and it's just a blink of an eye, and all of a sudden you're at a creatinine of 5. But the GFR testing is a straight line, so you can predict and make plans about going to college, getting a job, taking that trip. So patients lose their renal function at a relatively constant rate when they have diseases like cystinosis, but it's specific for that person. So here's someone who's got about 3 years worth of GFR, showing pretty much a straight line. But then when I start adding other people, they all have different lines, but for most of them, they're pretty straight. And so you can kind of make predictions for a lot of people. So the need for dialysis and transplant can be predicted, but not always. So this is a patient that you have to look at. So this is a teenager I looked after, and this was his GFR graph, and see how it was going down, 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 down. It went below 15. We said, okay, time to start dialysis, and he said, over my dead body. And you can't force an 18-year-old or a 17-year-old to sit in a chair 3 days a week. And he refused to go on dialysis, and for the next year and a half, it looked like his GFR stopped falling. Was it a miracle? Had he found the secret of life? Had he found something on Amazon that all of a sudden stopped his kidneys from deteriorating? Well, he lost 10 kilos. He had been a varsity athlete, long-distance runner. His grades went from A's to D's, and he was unable to exercise. He couldn't even go for a walk. So he was losing muscle, and he was sort of fooling himself. And finally, he said, okay, I feel like shit. Just let's get the transplant over with. And we said, look, you're out of shape. The risk of you having complications is higher. You need to go on dialysis for a while, build up your muscles, and then we'll transplant you. And that's what happened, and he did well. But you have to look at the patient, look at their weight, their nutrition, their muscle mass, their general health and activity, not just the serum creatinine. Now, if you're thinking, how can I figure out what my GFR is or my kid's GFR? This is the easiest way to do it. So I want you to remember the word Kidney Wiki. Kidney Wiki is a website which was developed by one of my students, And it's got all sorts of calculators on it. And on the lower left, on the left-hand side, you got GFR pediatric, that's from age 1 to 25, and GFR adult. And you can just go to Kidney Wiki, click on that, and you can plug in your own data. So what do you need? You need, this is kind of small, but you need the person's age, their sex, their height, whether your creatinine is measured in American units or the rest of the world units, you can plug that in. And there's also a chemical called Cystatin C, which is being used more and more and more. You know how I was telling you about creatinine is made by muscle? So it's also in protein. So there have been studies where if you've got a bit of kidney failure and you have a huge meat meal the day before your blood test, your creatinine's going to go up because you're digesting the creatinine in the meat, and then it goes into your bloodstream. So there's all sorts of things that can affect the creatinine. But the Cystatin C isn't affected by muscle. So in this graphic, we've got the GFR from the creatinine is 31. The GFR from the Cystatin C here is 47. So we average the two to get 39, and so that is the best estimate we have short of doing an actual infusion of a chemical and measuring it in your blood. And this is called the U25 GFR. It has been validated in 20% African heritage people, so it is race independent. And large numbers of Hispanic people were also involved in the development of this, so this is reliable. What if the creatinine measured GFR is much better than the Cystatin C? So we have patients where, you know, we're following the creatinine GFR and it's maybe 40, and you do a Cystatin C GFR and it comes back 20. There's a huge difference. Well, we start thinking about looking at the patient. So in people who are malnourished, people who have had amputations, people with eating disorders, and in my cystinosis practice, there are some people who are very active, doing sports, and there's no discrepancy between the GFRs. Sometimes even in the people that are really working out a lot, the creatinine GFR makes it actually look worse than it really is. But in many cystinosis patients who don't work out, who are not terribly active, they don't have a lot of muscle, and there's a big discrepancy there. And the data in the adult world shows that the bigger the discrepancy, the more fragile the patient is. And so this is an important thing to understand, that you know, as Dr. Gall was talking about exercise and taking medications, we know that people who have cystinosis can really make a difference to their quality of life by continuing to be active and push that kid into sports as much as possible. Okay, changing the subject. Patients with cystinosis, most of them will need a kidney transplant sooner or later. And unfortunately, the demand really outstrips the supply. So this is a chart showing that a couple of years ago, there were 800,000 Americans who had end-stage kidney failure in the United States. 800,000. There were about 80,000 who were on the transplant waiting list. So 1 out of every 10 people who have kidney failure are actually on the list. 9 out of every 10 are too sick or have complications or maybe have other diseases or realize that they don't have a chance. We only do about 25,000 kidney transplants a year. About 18,000, 19,000 deceased donors and about 5,000 living donors. So the vast majority of adults on dialysis will never get a kidney transplant. We call that their destination therapy. Now, it's different for kids and for people who can get on the list, that's the best thing you can do, but the wait times are long for adults. So this is the outcome of actively listed pediatrics. And again, I apologize, I don't have a good pointer, but I'm just going to use a pointer over here. So can I even see it? Oh, there we go. Not terribly well. Okay, I'll just have to describe it. So the blue line is of all the kids that are put on the list for a kidney transplant. And on that y-axis, there's 1 year. By 1 year, only 40% of the kids that were put on the list are still on the list. because about 40% of them have had a deceased donor transplant and about 20% of them have had a living donor transplant. In adults, at 1 year, about 60% of people who've been put on the list are still on the list, but only about 15% have had a deceased donor transplant. Many have been taken off the list because they got too sick or they passed away. So when you look side by side, you have a tremendous advantage to being a kid. And why this is important is that advantage is related to when you get evaluated. You need to be evaluated and put on a transplant waiting list before your 18th birthday to have the pediatric advantage. If you're put on the transplant waiting list after your 18th birthday, you're lumped in with adults. So if you're a kid, for example, this is how we allocate kidneys. So my team gets a call. We have a kidney from a person who had a car accident, family have given consent. So this is how they're allocated. So if it's a really good quality kidney, like the top 20% kidney, they go into sequence A. So if you're 100% sensitized and you are a perfect match, the kidney goes to that person anywhere in the United States. If you've been a living donor, a prior living donor, so this patient has given their kidney to a relative or a friend 20 years ago, and now they need a kidney transplant, that kidney will then go to them. And below that is pediatrics. And then substantially below that is your average adult. So that's why kids get a special consideration, and their transplants happen much sooner. Okay. Your waiting time starts either the first day of chronic dialysis or after evaluation and acceptance to the kidney transplant wait list by a kidney transplant center. Now, if you're over 18, the rule is you have to have a GFR of 20 or less. But we can list kids under 18 with a higher GFR. So if they're having symptoms, if you graph it and you see that the GFR is falling relatively quickly and you can predict that they're going to need a kidney transplant within a few years, we can put them on the list before a GFR of 20. So talk to your doctor about your child's GFR and the predictions of when they're going to need a kidney transplant. And the 18th birthday is the cutoff. They need to be on the list by their 18th birthday. If it's the day after, there's no do-overs. And so that makes a big difference. And so being educated to the rules helps you have educated discussions with your physician. When I started back in the 80s, most kids got a living donor kidney transplant. Now, very few do. So the blue line is the rates of getting kidney transplants from parents in the United States over the years. The big change is twofold. One is parental health. We have so much more obesity and diabetes, and that rules out people as a living donor. So if you have a 2-year-old with cystinosis and you're hoping to be healthy enough to be a living donor to them, go to the gym with your 2-year-old. Stay fit. Drink lots of water so you don't get those kidney stones, and keep your blood pressure under good control. Because parental health is the single most common reason to have to reject a living donor. But we're also having issues with single-family households. In the United States, over 50% of children are born to a single-parent household. So if I'm a single parent, I want to donate to my kid, how am I going to work to pay the rent, to keep insurance active? How am I going to look after my kid who's recovering from a kidney transplant when I myself have the incision? So having single families is also a barrier. And a lot of this is financial and economic, which can be fixed if there was advocacy that would provide better supports for living donors. Okay. So barriers to living donor health, poverty, people who have to work 2 jobs. Immigration status. Many of my patients are illegal aliens, or their parents are illegal and don't have access to health insurance, so we don't feel comfortable to take a kidney and potentially put them at risk. But many people do become living donors, and here we have the mom showing her scar on her lower waist, and her daughter showing her scar. And living donation is very safe. This is your risk of dying from being a living donor. And its surgical complications of donating a kidney, it's about 30 per 100,000. It's a little bit more common than being struck by lightning, But if you live in the US, you're much more likely to die of a motorcycle accident or a gunshot wound or a car accident. So considering the normal risks that you take every day, being a living donor is quite safe. But there is a consequence. So this is your risk of developing kidney failure and needing a kidney transplant or going on dialysis yourself up to age 80. What the insurance companies have noticed is if someone has been a living donor, they will sign you up for life insurance in lickety-split. Because if you've been a living donor, your chance of needing dialysis is a lot lower. That's that blue line. And why is that? Well, it's because you have had a battery of tests up the wazoo, imaging, colonoscopy, breast evaluation, cholesterol, glucose, diabetes, cancer, and you're clean before you can ethically be a living donor. So we have done the job of the life insurance company for them. So we know that if a person's been a living donor, their risk of death is lower and the risk of needing dialysis is much lower than your average population. But there is a cost. If you look at people who were brought in and accepted to be living donors, but they don't donate. So like in my program, when we have someone being worked up for a living donor, we also keep them on the deceased donor list. And sometimes like a couple of days before their scheduled surgery, we get this fantastic deceased donor kidney offer. We call them up. We say, look, let's have an educated discussion. We can go ahead with you being the donor, but we have this wonderful kidney offer. And we have to make a decision based on your values and your morals and your beliefs and your health. And sometimes people will go and say, let's do the deceased donor. So people who were allowed and accepted into a living donor program but don't donate, that's the healthy non-donors at the bottom. So what that translates to is about, my graphic is in white there, I need to change it. About 1 out of every 125 people who are a living donor themselves will need a kidney transplant in their lifetime when they otherwise wouldn't have. So that's it. So that's really the cost, 1 out of 125. Now, if that's you as a living donor, you go to the very top of the list, and so you won't wait more than a couple weeks for a kidney transplant. But we want to be totally transparent as we educate people about what are the risks. Living donation has a greater impact on renal allograft survival than HLA matching. So the data shows unrelated donors, friends, teachers, members of the congregation at your church, altruistic donors who show up to my program and say, I have a good life, God has blessed me, I want to give a kidney to someone on your list. You figure out who. They all work better than having a well-matched deceased donor. The advantage of having a kidney that is really healthy, that hasn't been in a dead person, is huge for many reasons that immunologists love to talk about for hours. But the bottom line is, for most people who say, I could be a living donor, but should we just roll the dice with the deceased donor first and keep mine in reserve? The answer is usually the best choice is no. Go living donor first. For one reason, we don't know if you as a living donor are still going to be healthy enough to be a living donor in 15 years when the first kidney poops out. You know, you might develop diabetes or get hit by a bus or something like that. The other last couple of bits of information I want, and cut me off if I'm going over time, right? Okay, almost, okay. Is when you're dealing with a program that looks after adults, most adults who get kidney transplants are in their 60s, they might have diabetes, and most adults who get kidney transplants pass away with that kidney working of their underlying disease from their diabetes, from their hypertension. So the most common cause of graft loss in adults is they just die. So what that means is for most adult kidney transplant programs, all you need to do is get a kidney into somebody and they're going to be happy. But with cystinosis patients, we are young in the population. People are needing their kidney transplant in their teens, in their 20s, in their 30s, hopefully going to live another 30 or 40 years. So when you get called with a donor offer, they might tell you what the KDPI is. Now, the KDPI is the Kidney Donor Profile Index, with 0 on the y-axis being the best kidney possible, and 100% meaning a really bad kidney, but it's better than staying on dialysis. And so this is graphed outcomes. The blue line is at 1 year, and the red line is at 2 years, showing that if you go from a wonderful kidney with a KDPI of 0 to 10 down to a really poor KDPI, the graft survival drops. But so if you're only going to live for a few years because you're 65, that's great. So your last few years of your life, you're going to stay off dialysis. But if you're hopefully going to be around for 20 or 30 years, the KDPI is important. And you have to think about that in your decision if they offer you a kidney to accept it or not. So let's look at 8-year outcomes. If the KDPI is wonderful, 1%, on average, there's a 72% chance that kidney is still going to be functioning 8 years later. On the other hand, if the KDPI is the poorest at 99%, there's only a 25% chance that kidney is still going to be functioning. So there's a huge difference. So when you get your donor offer, ask what the KDPI is, and if it's, say, 30 or 40%, that's worth going for. But if it's like a 90%, that's only going to be working for another 4 or 5 years. Maybe you need it because you have no dialysis access left. Maybe you need it because you're just doing so poorly on dialysis you'll take any kidney. But if you're not doing too badly, maybe you can wait till a better one comes along. And that's a discussion to have with your transplant coordinators about what kind of kidney you want and what's the right for you in your healthcare system. Polyuria. One of the things that happens, I get calls at least once a year. A patient has had a cystinosis patient has had a kidney transplant at another center. They left the kidneys in, and the child was making a ton of urine before the transplant, and they figured that that was just going to fix itself, and the kidney has been damaged by recurrent episodes of acute kidney failure and dehydration. I can't stress enough, in the cystinosis community, this is something that transplant doctors don't understand. If your child is drinking a huge amount, getting up at night to pee, drinking at night, and they do a kidney transplant at that point, there's a significant chance that that transplanted kidney is going to be damaged because those cystinosis kidneys are still going to be pouring out urine, and there's not going to be enough blood flow to really give the transplanted kidney what it needs. And every year, I give advice, go back and take out those kidneys afterwards, and sometimes it's too late. There's been permanent damage. So this is just something that the cystinosis community you need to know about if you have a child who is drinking a huge amount and is getting ready for transplant. So at the same time as the kidney transplant, they can take out one of those kidneys, and that makes a world of difference. So that's our practice at my center. A couple more minutes, or should I stop now? Pardon? Wrap up. Okay. So next time I come back, if I'm ever invited again, we'll talk more about how to help your kidneys last longer. But in the meantime, thank you very much for the attention, and enjoy the conference.